And I was supposed to talk about study designs, basics, and then we'll talk about what can really improve your writing with the introduction and methodology, and what can really spoil, what can destroy your research in terms of validity, reliability, and some sort of bias as well. And I'm supposed to start from 8 till 10:30. Let us run it the way and I think I just come across this in a way إنه توصل الفكرة بشكل انسيابي بحول الله تعالى. طيب. Now, first of all, طبعا, I have to congratulate you to really start with your research question and you construct your hypothesis, and now you're ready to drive. And to drive, again, think basics. When it comes to clinical research, you're dealing with either quantitative research. This is most of what you do. Quantitative research means you're dealing with numbers, you are measuring numbers, and you are estimating odds, relative risk. So you're really dealing with numbers. This is most of what we do in clinical research. Qualitative research is another interesting aspect of research. This is not really directed toward numbers other than toward talking to people, listening to people, getting their opinions, and then summarize what you found, come up with a conclusion based on non-numerical outcomes or variables that you obtained. And once you start your problem, I'm sure you came across the PICE, or the population intervention/exposure, comparison, and outcome. I will try to apply this whenever I have a problem that we need to translate to an idea that need to be designed in a clinical research fashion. Okay. Most of what you are dealing with will be exposure and outcome. Yani really think of it. You are going to measure an exposure. You are going to see the effect of an exposure on an outcome. You are estimating an outcome based on exposure. This is هذه طريقة سهلة. This is easy way to really think of what looks like maybe a vague, broad idea. Just make it simple, and then you go more specific. This is always the way to come up with your research question. And I think an easy way to think of it is, what is my exposure? What is my outcome? Marathani, this applies very well to quantitative research. Quantitative research, you are really it may not fit this very well. And I came across this example for those who may attend the workshop done sometime 2 months ago. Again, it is more or less the same idea. You come across this article about COVID-19 and its association with acute hemorrhagic necrotizing encephalopathy. This is a type of encephalopathy, usually viral, but because of this pandemic, researchers observed, and even clinicians observed that maybe it's associated with COVID-19. This is already published. You don't have to repeat someone else's work unless there are sometimes reasons that you need to challenge the fact already published. But let's think of as a problem. I wanna do it in a different way. Because always in research, you try to be creative. You try to come up with a new thing. That doesn't mean you are trying to invent the wheel. Let's keep it this way. Now the question will be, what is the association between COVID-19 and temporal lobe MRI signal changes in patients with acute encephalopathy? I'm looking at the temporal lobe, this part of the brain, and I want to see not only acute hemorrhagic encephalopathy. No, I want to really go more specific. Is there any specific pattern for the temporal lobe involvement in those who had COVID-19 and appear to have encephalopathy? And this is a research question. If you come across a research question, you try to go specific. You try to get some complexity into what you're doing. And this is what I am proposing as my research question. Now let's apply the PICO. Let's apply the PICO here. So the population is the patients admitted with acute encephalopathy. The intervention is the presence of COVID-19, or the exposure, the comparison, I want to compare them to those who had no COVID-19, but also had encephalopathy. And I want to look at if bilateral MRI changes in the temporal lobes is associated with COVID-19 encephalopathy. This is an intro to what I'm trying to do in terms of research design. Again, you always think of exposure, outcome, and this can make your research, constructing your research question a bit easier. This is true and valid for your hypothesis. When you design your study and when you do the data analysis, it will be an exposure / outcome, or explanatory and response variables. Yani whether you are using a methodology terms or statistics terms. When it comes to outcome, make sure you know it is a measurable outcome. You are measuring mean or median. You are estimating or measuring odds ratio, or you are measuring risk, or you are measuring a rate. Again, this applies very well to quantitative research. When it comes to qualitative research, you don't have a measurable outcome. In fact, you are trying to collect people's or / participants or patients' experience, perception, feelings, or anything that you cannot really measure other than it really an experience related, or it is based on opinion. This is a qualitative research. Sometimes we combine both. You have, it is more of a qualitative research, but you still have something that is measurable that you can express in your results. So you can mix both. And I love this pyramid. This is what I personally use to think of what quality of work I'm going to do. Again, this applies very well to quantitative research. So if you go higher up in the pyramid, you have better quality of evidence. If you go to toward the bottom of the pyramid, you may have some problems in how good the quality of your work is. Many people, even many students, they are doing good quality cross-sectional studies. So it is really midway of the pyramid. So definitely it is better than if you just write a case report or case series. Definitely it is better than my personal opinion as an expert when it comes to quality of evidence. And then you can go higher up with case control, cohort studies, or randomized control trials. The best evidence, of course, is systematic reviews and meta-analysis, or clinical summaries are the top. We will go through some different designs, and you will find yourself climbing up the pyramid in order to come up with good quality work. Always, when you try to answer your research, the way you tackle your question. So people can believe your work. People can rely on your work in their clinical practice. Always you try your best to make sure your work is valid and it is reliable. And this is how can I introduce the terms of validity and reliability when it comes to clinical research. It is not a difficult topic, حقيقة, the validity, reliability. Like as we go through this, you really need to put them in mind so you can come up with good quality work. And even the pyramid of the hierarchy of evidence, it is more or less affected largely by reliability and validity. So what is reliability? How to make sure you do have a reliable work? Simply, reliability means if you keep repeating your test, you will have the same results. So it is consistency of the results using whatever tool you used. And it can be across time, it can be across items, it can be across researchers. You use the the same test was repeated different times, it will produce the same results. Or you used a different test to measure the same outcome, it will bring up the same results. Or different researcher used the same test or a different test, he will come up with the same results. So reliability maybe is an easy thing to digest. Yani it really reflects how reliable, how consistent your finding is. You need to think of this when you really plan your quantitative testing for sure, quantitative study that you are doing. The validity, on the other hand, the meaning is a little bit, it is easy, but the application is a little bit maybe can be tricky. So once, if you are really measuring what you are supposed to measure, this is validity. So the valid test is what truly, if it truly measures what it is supposed to measure. For example, the score you obtained really represents what it was supposed to measure. So here we are talking about not consistency, or rather talking about how accurate is the measure that you are using. But always you will be bugged by the reliability, the validity of the way you collect your data, the way you interpret your data, and the way you come up with the conclusions. And this is very crucial. This is very crucial. Now, I will start more with the validity because maybe it's a little bit difficult, a little bit tricky to estimate. Now, a lot of times, if the reliability is secured, the validity is more or less secured. Different types of validity you're using. So as one of the examples is face validity. For example, you want to assess anxiety level, but you use the tool to measure severity of depression or suicide ideas or manic episodes. So now, clearly this is invalid because it is not really, you're supposed to measure anxiety, but you use the tool that measures something else. These are the three common examples of validity. الفكرة هنا إنه you need to really keep this in mind. You don't have to memorize it, but just put it in your head when you are really planning your study. So the content validity, so the extent to which a researcher, your instrument accurately measures all aspects of the outcome you are measuring. So now, for example, if the instrument you're using cover the entire domain related to the variable. مثلا, I'm trying to screen for anxiety. I use the tool that is good to tell me if anxiety is present or not accurately, and then sometimes it can tell me the severity of anxiety based on one tool. So it really goes beyond a different domain, different aspects of the measure you're trying to estimate. On the other hand, construct validity, you try to, so the extent to which a researcher or your tool measures the intended construct. For example, if the score of an anxiety, as an example, if the score of anxiety was high, it's supposed to, does it really reflect high anxiety level, or it only screens for anxiety, but the high score or low score, does it really reflect the anxiety level? The better one is that screens and really give you the severity of the measure according to the severity of the scale. Criterion validity, simply in whatever tool you're using, can you compare it to the gold standard tool available? The best tool that you're using with high criterion validity is the one that is really comparable to the gold standard tool used in other testing. Now, I give you just another example of overlap between the reliability and the validity. Suppose you are using the glucocheck or the glucometer, the bedside blood sugar test. I don't know if there are other names. It should give you a reliable blood sugar test, no matter what is the age, and if it is done by a nurse or a different nurse, if it is done by the physician or the patient himself. So this is a reliable, so there is consistency in the findings. But for example, if this glucocheck has a technical difficulties that gives you 10 milligrams per deciliter lower readings than the actual readings. So it will always give you a 10 milligrams per deciliter lower readings, no matter what age, who will do the test. So it is still reliable, but it is invalid because it gives you wrong readings. So these are some examples of how reliability, validity may overlap. Maybe in practice, your reliability is a bit easier to measure. Validity is a little bit deep. You have to think of it, you have to consider it. Even in statistics, there are ways to assess the reliability objectively by numbers, and we don't have to go through this, but it's an idea of you have to think of validity, reliability. Now, you need to secure validity when you are planning your research. Now, how would you think of a validity? How to think of it from the beginning, during the study design, during the data collection. Your measurement techniques should be a high quality. This high quality probably are the standardized questionnaires, if you're using questionnaires, or standardized screening tools, diagnostic tools, or what have you. And you are really targeting the population that this really can measure the outcome of your interest. For example, I am trying to measure anxiety in adolescent or young adults. It will be wrong to give my screening tool, my diagnostic tool, to everyone that includes older population. It may really give me a good anxiety screening, anxiety diagnostic tool, but it is really away from my objective topic in the research, that is anxiety with adolescents. So you really have to target the population. This is very important. And and it should really reflect what is going on, what is the real knowledge, what is we know. You cannot just create whatever tool and you don't know how reliable, how valid it is, and you need to use it as a solid way to screen for a disease or to measure an outcome. The results reflect the real variation as accurately as possible. To also ensure your validity, you have specific population, target population, either specific age, according to your research question, in a specific location sometimes, and for example, a specific profession. I want to test an anxiety in emergency physicians, and it will be useless to get an engineer respond to my screening, even a neurologist to respond to my screening. So you have to really hit your targeted population. Sample size does matter. The smaller the sample size, the more likely you get false results. The larger the sample size, the better, the more accurate or toward the real effect you are going to get. And remember, whenever you do a study, you pick a sample, you try to, the sample should really more or less represent the whole population. You cannot screen the whole population. It is pointless. So whatever sample you take, keep in mind this should really reflect the population. And you cannot, or you don't have to, or you should avoid put pressure on the participants that may change their response because of your influence. Sometimes you do it unintentional. And I sit with an epileptic patient, and I have a valid, reliable screening tool for depression in epileptic patients. So when I ask him, مثلا أقول له أنت التول هذا السكرينينج ده وأسأله، بس أقول له أنا عارف إنه مؤخرا أنت كنت ما أنت مبسوط وزعلان قلت لي الكلام ده. So now this will reflect on his response. So although I do have a reliable tool, but now it is invalid because I influence his response. So these are things that you should keep in mind when you are really checking, testing for your validity. Reliability, again, this really reflects the consistency of your tool that you're using. So how would you really make sure it is a reliable test? It should be executed, done the same way in all participants at different levels of the test. And for example, pre-intervention, post-intervention, you should use the same tool in the same way. Even if it is used by single or different researchers, it should really be the same steps. And you go by the book. And when we discuss how to write your methods, you should really be well stated that the measure, the tool, whatever you are using was really conducted in the same standardized method throughout my study, throughout the different participants, or even by different researchers. So, and the best thing to really, you need to standardize your research. The easy thing to do is you use a standardized tools and make sure you use it throughout the same levels in the same way. And very important, you use the same test under the same conditions for all the participants. Anxiety level, as an example, or depression scale, or the blood sugar measures, for example. You should make sure it is used under the same circumstances for all, or similar circumstances for all participants. This is now a quick way to really look over reliability versus validity. Always remember, reliability is consistency of the test. Validity is, it really should give you the same measures that you are intended to use. It's more or less kind of accuracy. And we talked about how to assess it, how to really keep it in mind. It is very nice. It is good for you to really show that you are thinking of reliability, validity during your writing. Even when you are searching the literature, you will read, previous researchers, they really state, they try to really use this reliable/valid test. They did their best when they are conducting the study to make the test still reliable and valid. This is when you are doing your literature review. When you plan your own methodology, sometimes it is really nice to really state it very well. We use this screening tool / a diagnostic method / whatever that was all were valid, reliable, and you can show this and you can cite and put a reference for this valid, reliable test. So I'm a reader, independent reader. I can really secure, put you in my head, you know what? They did the job to really minimize issues with the reliability / validity. You do your best. Sometimes it can happen. You may have difficulties in ensuring the validity or reliability, but you do your best. When you interpret the results, again, you should be very reliable, very objective. You should show, the results were interpreted in a valid way, even in your discussion, even your conclusion. So put it in your head, think of it, and when you apply it, even through interpretation, discussion, and conclusions. Now, sometimes you can have an error during your study design, study methodology, collecting the data, interpreting the data. And errors are there. You will find error in your data collection, data interpretation, and sometimes even the conclusion that you come up with. Let's assume that there is a new medication that is supposed to really shorten the hospital stay in patients with stroke by 4 days when compared to the old medication. So the best ideal results are when I tried to know one patient, it really reduced his hospital stay by 4 days. Tried in different patient, it will give me more or less the same results. All subjects enrolled in the study, they have 4 days shorter than standard or the old medication. Well, this is maybe impossible because we do have a different biological responses to medications, but this is the most ideal way to really think, you know what, wait, my tool was really reliable because it is very consistent results, and considering your study design, blah, 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 probably it is valid. The other scenario is, the real difference is 4 days reduction with the new medications compared to the old medications. The results were varied across different subjects, range from 1 day reduction, 7 days, 6 days, and what have you. So you will have different responses, but they are all going around your average, the 4 days. So here, well, we do have variation in our responses, biological variations. Okay? This is a random error. There are ways, and I will show you now, how to minimize this random error, how to really make the mean goes around the real mean. Yani all your results really goes around very close to the mean. You don't have to really make your results definitely 100% equals to the mean, but at least they are going around the mean. The worst case scenario that this medication reduces the hospital stay by 4 days compared to the old-fashioned medications, and your results showed different numbers. Of course, we do have biological differences, but if you really lump your average, you look at your average, it will be definitely away from the average, from the real effect. To you, it looks, they're consistent. They're all going around, average maybe 7, maybe 6, plus or minus. But previous studies showed it was 4. So you have to really think of what is going on. So this is a systematic error. This is something you should avoid. This is either because of, options are, is it the old study was wrong and you have more accurate results, or your study was faulty because of a systematic error. Systematic error is a red flag, big threat, can kill your study. This is a threat, big time threat to your validity. So you can have a random error. A random error is normal variation between ourselves. This is happens by chance. Sometimes you cannot predict it because the responses are different. The problem is that systematic error, that is bias. This is, you can predict this during your study design, according to the study type that you're doing. And this is something you can predict. And this is something you can really think of during design, during data collection, data analysis, and conclusion. So we will talk a little bit about bias. What is bias? هو إيش اللي هو انحياز مش كده بالعربي. So simply you are going away from the fact. You are heading away from the reality. Intentional, unintentional, this is a different story. In methodology, it is a systematic distortion of statistical results due to a factor not allowed or in their derivation. I just give some examples of bias. Any systematic error in design during your analysis, this will lead to a mistaken estimation of the real effect of the exposure on the outcome, and that 4 days example can make it a little bit more easy to digest, I guess. So bias virtually any study in epidemiology. So you have to really think of bias each time you are planning a study. Bias versus chance or random error. If you have a larger sample size, the chances of falling into a random error will minimize. I don't think it can be 0 because we do have differences in our responses. You have differences in interpreting the results. But the systematic error or bias will be consistent, no matter you have the largest sample size, even the largest sample size that you can think of, because you were a victim or you were trapped in a bias. It will be consistent throughout. So that's why you have to really think of bias ahead of time. So again, in all researches, sometimes difficult to eliminate unless you are really thinking of it. You try to minimize bias. Sometimes it may be difficult to really omit it completely, but you try your best to minimize bias. It can occur at any stage of your study. It can impact the validity and the reliability of the study findings. And it can really misinterpret the overall conclusion, and you come up with wrong conclusion. So here are some examples of bias. We'll just come across few examples. The bias is, types of bias can be very thorough, and we don't really have to go through it. Like, I just show some examples you can think of it more or less in a practical way. Okay. Now, you do your best. Imagine you do your best to minimize bias. You may not really be 100% able to kill it, but at least you minimize the bias to come up with good quality work. During study design, you may be a victim of a design bias, and I will show you some examples of studies that you will be you will have a bias big time unless you are careful to improve the other ways of the study to minimize the bias. During the enrollment of the participant, you may be faulty of selection. Okay, you can fall into a selection bias. You only select people, حتى لو unintentional, you select people that will give you better response than if you select everyone else during your study. Assessment of the participants, you can really have a measurement bias. Again, like if I sit with someone and I put my influence on him during my interview, I can't just drive him to give me an impression that I'm looking for. حتى لو أنا unintentionally I did it. So this is measurement bias. Sometimes data collection bias. When I collect the data, I overestimate findings on those whom I want to overestimate. For the analysis of the results, there's sometimes analysis bias. You really overestimate the effect in the exposure people, for example. Sometimes unintentionally that you may be a victim of analysis bias. Sometimes publication bias, if you are reading an article, you want to study and start doing the literature review, you'll find yourself, for example, looking only into the results or the studies that has a positive effect, that have a positive effect, and then you may fall into publication bias. Okay, now go through study designs, and I'm sure you may come across this. You may have seen it in different times. You may have seen my own examples in different presentations. Like it is going to be an discussion, and then we can have a few minutes to really throw your ideas and what is the best way to study it. Now, let's assume researchers wanted to understand the association between skin cancer and exposure to hazardous radiation. So, and your research question is, what is the association between skin cancer and exposure to radiation in Jeddah? I'm really specific to really think of the risk of skin cancer because of this exposure, and I really define my population in Jeddah, in one city, for example. And I come up with my PICO. The population is the resident in Jeddah. The intervention is the radiation, and the comparative group is no radiation. Intervention or exposure. عشان ما يقولوا إنه I don't do the intervention myself. لكن هو intervention or exposure is the radiation. Comparison is the no radiation. And my outcome of interest is skin cancer. So now, no matter how complicated the topic is, I'm trying to make it simple, objective, and easy to make my life when I really proceed, when I do my study design, my analysis. So now here, I'm really looking at a risk factor. Let's assume this exposure, this radiation, particular radiation is not common, but there are some observation, it leads to skin cancer. If I listen to an expert, an oncologist, and he said, yes, we have many cases of skin cancer after exposure to this type of radiation. Well, it is well-respected observation, like it is really at the bottom of the pyramid. Now you want to understand, you want to test this hypothesis through a better way to come up with a better quality of evidence. Let's go through this. Again, when you really do your study, you have your population, but you are trying to really come up with a sample that is a representative of a population, and then you can really and it should really reflect your population. This is what always do. Whatever sample we come up with, it should really reflect what is going on in the population. So this is a pyramid, Mauritania. I look at the opinion of an oncologist versus I am just collecting cases and I'm coming up with descriptive analysis. This is case series or even case report, one case report. It is even better than probably the opinion of an expert. That is only opinion from observation without objectively, systematically, scientifically come up with this observation through a study. Now we will just climb this pyramid with different study designs. I will start with cross-sectional study. By the way, cross-sectional study is a lovely type of a study. It can be the beginning to come up with association between exposure, outcome. It can be a good tool to understand. It cannot tell you exactly what is the cause, what is the effect, other than association. Let's go through this. So we have a sample, and we will think of, we'll have eventually two groups, those who had a skin cancer, and those who had no skin cancer. Because this is the exposure, this is the outcome. This is the compared exposed group and unexposed group, and the outcome is the skin cancer. And those who had skin cancer, some of them were exposed to radiation, and others who never been exposed to radiation, but they have skin cancer. This is life, Those who had no skin cancer, you will find some of them were exposed to the same radiation and never had a skin cancer. And of course, the other had no skin cancer and never been exposed. So this is your scheme. This is your workflow. The way to think of what I'm going to expect. If I do a cross-sectional study from a sample, I will eventually have two groups, exposed and unexposed. And in each group, I will have, outcome with no outcome. And then I will have exposed and unexposed. So how will I do it? I just go back one step, sorry. So I will go to my sample. I estimate, I know my targeted population. I estimated my sample size, and then I just screen them. It is a cross-section at one specific time. I screen them. Do you have a skin cancer? Yes or no? Have you been exposed to radiation? Yes or no? I'm trying to make it simple by only this simple question, but sometimes there are objective way to really look for exposure and exposure. If let's assume I'm targeting professionals who work in a high field radiation exposure, they objectively have a measure that they put every day. It's a tag that can give you an objective radiation measure per day, وعندهم daily record, وعندهم monthly record. طيب, I can estimate the average per week or per day or per month or what have you. So this is very objective. بدل ما أسأله yes or no ممكن ينسى. So this is a recall bias. يقول لي لا ما I know I was never exposed or I was really exposed without objectively knowing was he really exposed or not. So there are other objective way to really see what was the exposure. You measure the exposure based on the tag they have that can measure the daily exposure. And then if I want to know, do you have skin cancer or not? بدل ما أسأله, sometimes people have just whatever skin changes and he calls it skin cancer. لا, I go to the medical record and I really see who had skin cancer, who never had skin cancer. So I go to all my population of interest, the sample that I'm collecting, and I objectively trying my best to really see who been exposed, who were unexposed, and then who had the outcome, who never had the outcome. And again, I will really have two groups, exposed and exposed, with or without the outcome. So this is cross-sectional study. It is easy to do. You can do it quick, and you really can have a good association between exposure and outcome. Other different study that you may do, which is really good study design, this is really good for risk factor. By the cross-sectional study, it will give me an association between exposure and outcome, association between radiation and skin cancer. Case control study, it will give me is it a risk or no risk? So this is very good for a risk factor. Actually, we reserve the case control for uncommon diseases. Uncommon diseases definition يعني if the prevalence ويعتمد طبعا يختلف if the prevalence is about يعني less than not more than 10% يعني diseases with prevalence up to 10% between 5 and 10% case control can really give you a good idea of the risk or no risk. So now in case control I start with two groups. I start with those who had skin cancer. I also have a group who had no skin cancer. يعني instead of I go and look for them, no, here I start with the outcome على طول. And then I ask them for the last 6 months, for the last 1 year, have you been exposed to radiation? And the answer will be either yes or no. So now I start with my outcome from the beginning. And instead of I look for the outcome, I look for the exposure في cross-sectional study. هنا case control, I start with the outcome and I ask back in the past. So this is a type of retrospective. طيب. وهنا في مشكلة كبيرة اللي هو recall bias. This is يعني a well-known bias in terms of the case control. Again, recall bias, إنه the subject he cannot remember. يقول لي no, in fact, he had the exposure. So I have to take it as no, but I have to keep in mind, there is a risk of recall bias. Even those who had skin cancer or no skin cancer, it can be either exposed or unexposed. So case control, I start with my outcome, I ask in the past. This is a good for risk factor analysis. Again, I just go at the back. Sometimes we do what we call matched case control. إيش يعني matched case control? I only take those who had skin cancer, 30 years men, I compare them to those who had no skin cancer who are 30, who are at the same age, at the same sex. يعني the same age, same sex, equal groups. أنت ممكن تفكر فيها تقول هنا oh this is selection bias يعني you are really selecting your subjects. That's why you cannot really talk about prevalence or incidence from case control because you are selecting people. This is not selection bias. This is the study design. ممكن تفكر في selection bias في case control إنه I want to study anxiety among the population, but I go to a very anxious population. This is mid students or university students. So this is a selection bias. You will have higher anxiety than the real population because you had a selection bias. Case control, this is not a selection bias. This is the study design. So this is what we call a case control study matched for age and sex to come up with the equal groups. You don't have to have a matched study, but it is a better way to really come up with matched case control. And then again, you ask in the past, exposed or unexposed. So again, quick comparison between case control and cross-sectional study. Case control, you start with the outcome. Well, the cross-sectional, you start with no outcome and you look for the outcome. In case control, you look for the exposure, but in cross-sectional, you will look for both exposure and outcome. Case control, you cannot look for prevalence, while cross-sectional, it is sometimes called a prevalence study. This is a best simple study to look for prevalence. example حق cross-sectional skin radiation. When I did my skin cancer, when I did my screening for all my population, I screened, for example, 1,000 subjects, and I found 100 of them had skin cancer. So I can comment about prevalence based on my population. The larger study, the more sample that is representative of a population can give you a more reliable prevalence. Case control is a retrospective because you go at the past, you ask about the past. While cross-sectional, it is the current time. In case control, you can only estimate the odds ratio, while in cross-sectional, you can estimate the relative risk or odds ratio. These are measures of association that are very important to use to objectively give you, to quantify either the risk or the association. فهذه مهمة. طبعا case control is good for risk factor. Cross-section is good for association. Case control and cross-sectional are cheap, easy to do, and very good evidence, quality of evidence. At least it is better than case series, case reports. definitely better than my opinion as an expert. So this is easy to do, and mid students can really come up with good case control or cross-sectional study, given the fact that you are really doing a case control or a cross-sectional study. Then sometimes we mislabel study as a cross-section, which is in fact nothing. Right. Now let's assume an orthopedic surgeon started to see more cases of shoulder dislocation in his clinic. It noted more than the usual, and it really hits his head. You know what? As if there is something wrong. Why I have more cases of shoulder dislocation? On further questioning, he asked his patients. They start to really talk about a new technique they are performing during in the gym, in exercise. And he was thinking, you know what, is it associated or not? And now this can really come up with his really burning research question. Was the exercise, that particular exercise technique associated with shoulder dislocation? And now this is the research question. To be really more specific, what is the association between shoulder exercise and shoulder dislocation in patients younger than 40 years of age? ليش أنا اخترت 40 years of age, for example? Because these are the ones that really goes to the gym. These are the ones that really more likely to do this type of exercise. This is not a selection bias, and I really went more specific to target this population. For this, and I'm just challenging myself. Am I really? Did I really fall into a bias if I select this particular population? You have to really put this reasoning when you do your methodology. And I am really interested only in this younger population because I saw it more in young than in adult, or these are the ones who really more likely to do this type of exercise. So this is my PICO. The population are patients younger than 40 years of age who exercise at least 3 days a week. I have to really go more specific. And this is my assumption. This is a way to really pick my population. ما أبغى واحد عملها once in his life وأقول إنه this is included. Unfair. لأنه only had exposure once. It is different than those who really go to the gym more frequently. So that's why I need a minimum of 3 days a week gym in order to enroll them in my study. The intervention or the exposure is that specific particular new routine that I thought maybe it is associated. My comparison group is those who had different routines other than this new shoulder technique, shoulder exercise. And my outcome is a shoulder dislocation. Now, let's just go through, I want to check if this is a risk or not. So I am doing a case control. Right? Assuming again, shoulder dislocation is uncommon, or assuming this really fulfilled to check it as a risk. Right? So now I will have two groups. I will have my patient who had the outcome, that is shoulder dislocation. I'll compare them to healthy subjects or patients who had other diseases other than shoulder dislocation. Or the best way to do it is healthy. So you will have two groups, one with the outcome, one without the outcome. And then I can match them for the age and sex. The same matching, 30, the same age, the same sex. أخذ 30. كل ما أخذ واحد 30 years of age man, أخذ 30 years of age man in the control. So on and forth. إلى ما I come up with my 100, 200, whatever sample size I wanna reach. Right? I will ask them all the same question. So now I'm doing to really have my screening tool valid and reliable. I will assess it in all patients. ما أجي على those who had shoulder dislocation حتى طريقة كلام معاه أقول له أنا عارف إنه ده التكنيك عامل لك shoulder dislocation صح ولا لا؟ هتلاقيه هيقول لي يمكن أيوه. غير إنه أروح للهيلث يقول له do you think the shoulder dislocation was do you think that exercise ولا أقول له have you done this shoulder exercise؟ يعني كده سؤالي حيكون did you do that shoulder exercise yes or no؟ فما اجي حق الديسلوكيشن اقول لهم انت عملت ذاك الاكسرسايز صح ولا لا؟ بينما الثانيين اقول له انت سويت اكسرسايز؟ فهنا I don't want to have my interview bias انه انا I just pull the data in a way to fit my حتى لو indirectly my impression. وهنا another bias that again recall bias can be an issue مع الريسك. يعني يقول لي انا ناسي عملته 3 مرات ولا يومين ولا اسبوع واسبوع لا. It can be an issue. And then this is again retrospective as in the past. Let's see what happened. For example, I did a really good study. I collected 2,000 subjects in each arm. and you can do it. This is not like, oh, this is imaginary. No, you can do it. You can just يعني مثلا تروح لأورثوبيديك كلينيك as an example واقول له تعطيني ممكن كل الليسته حقت الشولدر ديسلوكيشن for the last 6 months. اروح I go to different hospitals. طيب at the same time اروح لأورثوبيديك كلينيك عشان ما يكون في selection bias. اقول له اعطيني ابغى مثلا ممكن 30 years old man who had جاك العياده بسبب ثاني غير الشولدر ديسلوكيشن. So he will be healthy or who will be those who never had the outcome. I can match them وكلها easy. عند list I have a case I want to match them with the control. ارفع السماعه او I set them interview while they're waiting in the waiting room. اقول له يعني make sure they go to the gym at least 3 times a week واسال نفس السؤال to avoid selection bias. So now let's say this 2,000 patients in the shoulder dislocation. Some of them will have this exercise. Some others will never have this exercise. And it's same for the healthy subject or those who had other diagnoses other than shoulder dislocation. Some of them will have the shoulder exercise. اللي أنا فكر فيه إنه is it a risk for shoulder dislocation? Others will never have that shoulder routine. Now, these are the numbers that end up in each group. فأنت تطلع فيها كده oh nice يعني I really have a good sample. I don't think I have issues with the sample size. I want to make sure إنه we ensure إنه when we interviewed them we interview them equally without our influence, and we really يعني very carefully enroll those who met our inclusion criteria. إنهم younger than 40 years of age, who at least do 3 times a week gym visit. مو شرط shoulder exercise, who do at least 3 times a week gym. تمام? Again, 2 groups. again I go to the orthopedic clinic ولا waiting room عشان اتاكد انه ما اروح مثلا orthopedic مع shoulder dislocation versus cardiology clinic. ويمكن I don't really find someone who had the exercise يعني cardiology maybe they will not exercise because of cardiac risk. هذا شيء تحطها في بالك. These are things that should really be considered. These are the numbers. طبعا this is very factitious and I made up my numbers هنا don't quote me. خلاص. في حاجة هنا very common نعملها و very nice و easy you should really start to use it اللي هو 2 by 2. حط ال exposure هنا في ال x and y. exposure في ال vertical, horizontal يكون outcome. يعني shoulder dislocation, no shoulder dislocation, shoulder exercise, no shoulder exercise. وهنا I collect the numbers يعني number of people in this each category. مظبوط؟ بعدين I do this bar chart. This is a percentage of each. If you look at this without any further يعني sophisticated way to really analyze the results. If you look at shoulder dislocation group, طبعا هنا the blue is the shoulder exercise of my interest. The red is never had a shoulder exercise. Those who had shoulder dislocation, يعني 62% of them they never had a shoulder exercise versus 34% of shoulder dislocation had the exercise. So looking at this as if the shoulder exercise lead to less shoulder dislocation. مظبوط? And the other way around, a healthy control, يعني you can think of the same thing. I don't want to go through the details of the statistical analysis. Maybe you will come across it in different sessions. Now, I really want to measure the association. I want to make sure these results, are they significant or by chance? To measure the association, this is case control. I measure the odds ratio. Without going into details, أنا بقول the odds of the outcome in exposed versus the odds of the outcome in unexposed. يعني in this example, the odds of shoulder dislocation in patients who had shoulder exercise compared to shoulder dislocation in those who never had the shoulder exercise. I don't want to make it too complicated or technical. لا. هنا the odds ratio, odds يعني كأنها the probability, كأنها the likelihood of having the outcome if you're exposed versus having the outcome if you are not exposed. وهذه simple يعني you can do it manual or you can do it through the definitely statistical software. It will come up with a number. This is the math, don't worry about it. If the odds ratio is 1, معناه إنه there is no association. معناه there is no risk. So exposure did not lead to the outcome. If the odds ratio above 1, so there is an association or there is a risk, increased risk. If the odds ratio is less than 1, there is decreased association or decreased risk or protective effect. For more than 1, increased risk, less than 1, protective effect. Let's look at the numbers here. The same example here. This is description, don't worry about it. عملنا statistical analysis using software or 2x2. خلينا نعمل statistical software. The odds ratio was 0.3. And the odds of shoulder dislocation in those who had shoulder exercise was 0.3 compared to shoulder dislocation in those who never had the shoulder exercise. كده معناها. طيب. And this is what I'm writing here. So again, because it is less than 1, as if it appears to be protective. مظبوط. وهنا the numbers كأنها it tells this the bar chart. You know what? The shoulder exercise was led to less shoulder dislocation compared to no shoulder dislocation, and the odds ratio goes مع it goes with the diagram here. The 95% confidence interval. This is another good tool to really see the association between or the significance of your results. I'm 95% confident that the true effect of shoulder exercise to lead to shoulder dislocation ranges between 0.3 أنا أقربها to 0.4 0.28 to 0.36. So 95% it really reduces the shoulder dislocation with this range. مظبوط. And then so again, shoulder exercise increased the odds of shoulder dislocation by 0.3. Increased it by 0.3 معناها it is protective. مظبوط. This is, I'm just repeating myself. So what should that mean? It is protective again. Or you can say because it is 0.3 أقل من 1 by كم؟ 0.7 كأنها 70%. This is another way to interpret the odds ratio. لأنه 0.3 أقل من 1 by 0.7. 0.7 if you want to convert it to percentage, it is 70%. مظبوط. Now, another example عشان تخلي odds ratio. لأن odds ratio is very important measure of association when you are thinking of case control and cross-sectional study. And you have to really, it is very common to use odds ratio. It is one of the most common measures in any medical literature. They comment about the odds ratio. So this another example: job status and depression. being holding a job versus being jobless and association with depression. The odds ratio came up to be 1.5. This is an example without details. I just want to show you the examples here. The odds ratio of being depressed and jobless was 1.5 times the odds of being depressed and not jobless. My exposure is being jobless. The outcome is depression. So as if being jobless increased the risk of depression by 1.5 times. 1.5 times. مظبوط. This is the same thing. being jobless increased the odds of depression by 1.5 times. These are different ways to interpret odds ratio. ما بروح تفاصيل بس I really want to show you how easy yet how very powerful meaning of the odds ratio is. I also can say being jobless increase the risk of depression by 50%, or depression increase 50% in jobless compared to those who have job. ليش قلت أنا 50%؟ and 1.5 أكثر من 1 لأنه my cut point is 1. 1.5 أكثر من 1 by 0.5 اللي هو 50%. مظبوط. This is a different way to really comment about odds ratio. It's another example. You observe people appear to be more anxious when we talk about coronavirus, and this is too much news. And a nice, good assessment or question is, is there an association between more information, more knowledge of coronavirus, COVID-19, and anxiety? don't send Google Sheet to really look at this. You have a better ways to look at it. So my research question is, what is the association between following news or يعني, being more knowledgeable about COVID-19 and anxiety? So the population is community-based study in Jeddah, in Al Hafuf, in whatever city you wanna pick. This is my population. My intervention is watching news about COVID-19, and you should really come up with an objective way to determine what is watching news about COVID-19. يعني what is exactly, how can I measure this watching news? هنا now I'm really thinking of how objectively, how reliable tool I will use to estimate my exposure. صح ولا لا؟ Comparison is those who never watch news or don't watch the news. ممكن نخليها, do you sit on TV to watch the news at least one hour a day ولا how many times per week? هنا في recall bias, but at least I do my thing. أو ولا إنه I give him مثلا مثلا an iPhone that can really measure each time he goes to news or he Google COVID-19. This is a very objective way to really look at this. Compared it to those أقول even I give him iPhone أقول له مثلا just use it randomly طيب without going to COVID-19. So now this is an experimental study without going to news about COVID-19. وأنا each time he Google يعني COVID-19 ولا coronavirus ولا whatever keyword يجيني notification. This is a really objective way to assess the exposure versus the outcome. The exposure versus unexposed. My outcome is the presence of anxiety, and I should have a valid way to really measure my outcome. Either anxiety tool, screening tool, like anxiety diagnostic technique, or what have you. I'll show you some examples now. So this is that community. I collected a sample, and I have my different ways to either ask them or measure exactly if they're looking into news about COVID-19 or not. And either how many hours, how many, what have you. And there are objective ways to look into this if you can. And then I use this GAD1, 2, whatever, screening tool. This is validated, reliable screening tool for anxiety. I apply it to everyone. To everyone. So here is what will happen. So you will end up having patient, when you do your screening tool, you will have patient who had anxiety, and you will have patient who had no anxiety. Or ممكن تقول have mild, moderate, severe, or no. يعني mild anxiety, moderate anxiety, severe anxiety حسب التكنيك, or no anxiety. طيب. And then I have my other measure اللي هو they read or follow the news, or they have at least 5 hours or more per day looking into news versus less than 5 hours a day, or none. And I should apply this to both groups. الفكرة واضحة إنه I objectively screen them for anxiety, and I objectively measure this how many hours per day. ما تكون كده vague yes or no. Still yes or no sometimes can be, this is the way it is. لكن you will have difficulty يعني convince others in this is objective way to really look into your exposure. يعني this is the way to measure your exposure. Like this is an example, and you have to think of all this aspect when you plan your study. And now look, ما شاء الله كم عندي subject هنا 5900 يعني كم إن شاء الله فوق 16,000 maybe, يعني around 13,000-14,000. And these are the numbers in each group. I just collect يعني this is number of each according to the category that I'm having. So remember, and I can do this as my cross-sectional study. This is again, this is type of observational study. I look for both. I don't start with the outcome. I look for the outcome. I look for the exposure. And here I can only estimate the association. I can come up with the prevalence, that's why sometimes it's called prevalence study. Let's go back to this example. So I figure out, again, this is outcome, anxiety, no anxiety, اللي هو في horizontal line, vertical اللي هو watch news or no watch news, or مثلا ممكن أحددها 5 hours or more per day, less than 5 hours, يعني exposure versus non-exposure. Whatever objective method you can do, يعني you can really build up very good study. These are the distribution. بعدين عملت البار chart. If you look at those who are anxious, again, the light blue is those who watch news or those who had 5 hours or more news versus less than 5 hours or never had the news. كأنه yes, يعني those who are anxious, proportion of those who are anxious are more likely to watch more news than يعني those who did not watch news. مظبوط. Now, let me do more. Yeah, I can describe this. I don't want to go through into details. Because this is a cross-sectional study, I estimated my relative risk, and the relative risk was 1.7. 1.7, which means following the news about COVID-19 increases the risk of anxiety by 1.7 times. يعني it increases, there is increased association. Increased association between watching more news, or at least 5 hours or more of news about COVID-19 with anxiety. And this is the 95% confidence interval. Now, another assumption, you are intended to study the effect of smoking to develop lung cancer, and you want to follow subjects who smokes and develop lung cancer. And you do have the time, you do have the fund to really bring up this study. Now, my research question is, what is the association between smoking and lung cancer or bronchogenic carcinoma, whatever? So my population is people lives in Jeddah, again, people live in Jeddah. The intervention with exposure to smoking, comparison is non-smoking, and the outcome is the development of bronchogenic cancer. Now, this is my population at risk, and everyone is at risk if I think of bronchogenic cancer, مشكلة. So this is a population, and I follow them over time. I start معهم, I go, you know what, I'm going to follow you for 5 years, for 10 years. Right? You have the fund, you have the time, you have team that you can run this type of study. You will, over time, you will find people who smoke, you will find people who don't smoke. And then eventually, people will develop bronchogenic carcinoma, or people will never develop bronchogenic carcinoma. This is what will happen. This is a cohort study. This is you start and you follow people. You follow them either. هنا الexample حقي اللي هو prospective. You follow them over time. Sometimes you can have a cohort study with the outcome that comes short. Yeah, you can have prospective study over 3 months, over 6 months. You still have, because bronchogenic carcinoma, it won't develop over 1 month, over a few weeks. It will need some time. So you start a population or exposed group, and then you follow them over time. You can measure incidence. ليش you can measure incidence? Because you can measure the new cases. You can measure prevalence. And after 5 years, what is the prevalence of bronchogenic carcinoma in my population? You can estimate relative risk, تمام? Relative rate, because there is time. بدون ما أخش في التفاصيل هذه. Here we go. So the sample, and I never randomize them. I never randomize my groups. I just follow them over time. I cannot أقول مثلا in a group don't smoke when to smoke. لا, they will just live their life. I know they will smoke. Some of them will not smoke. I can follow them. I can either record through hospital visits. I can interview them every 6 months. Do you smoke or not? Yes or no, or whatever, how many packs per day, and so on and forth. You will end up having smokers who had cancers, or smoker who never had cancer, and also you will have non-smoker who developed bronchogenic carcinoma versus non-smoker and never had a bronchogenic carcinoma. So this is a prospective. I will follow them over time. And here are the numbers, again, 2 by 2. If you look at bronchogenic carcinoma, it looks like more proportion of them, they smoke compared to those who didn't smoke. كأنه في association. And you can only tell it by statistical analysis. So cohort studies, they're very good in calculating the incidence, confirm the temporality. إيش يعني temporality? يعني exposure will lead to outcome. So this is really cause and effect. If you're exposed and you have the outcome, yes, this is cause and effect. This is temporal association. You can minimize recall bias لأنه you keep follow them, تسألهم ما تقول إنه أنت قبل كم سنة you smoke, yes or no. You can actually examine more than one outcome. يعني not only bronchogenic carcinoma, I want to examine tongue cancer, laryngeal carcinoma, I want to examine bronchial asthma, whatever. يعني you can really, good about cohort study, you can estimate more than one outcome. You can measure more than one outcome. So this is a very valid look for association between exposure and outcome. One issue here is the survival bias. كيف يعني? You follow people, بعدين some of them, they moved from Jeddah راحوا مكان ثاني. I cannot follow them. So this is or they die, or they have different things. Sometimes يسموها lost to follow up bias. They will impact my results, but there are ways to really adjust for this. It is expensive, and you need time, you need effort, you need team to follow them, and you can't really look for a long run. And again, just to follow up, it can be a confounding. يعني it can really affect your exposure and outcome because مثلا smokers who develop lung cancer بس قبل ما يجيهم lung cancer طلعوا برا الجروب حقي، فكأنه smoking lead to nothing which is not accurate. فهذا مشكلة الكوهورت study إنه you may lose people. Different way to do the cohort is I go, so this is prospective. Sometimes I go retrospective. So I start from 2018 from now. أقول مثلا over the last 10 years, I will look at the record. Did you smoke? And yes or no? When I start, I know the outcomes, but I go backward over the last 10 years. How many packs a day smoke? If there is an objective way to really estimate how many packs per day, this can be a valid way to look at it. So prospective isn't expensive. You go forward. Retrospective can be cheaper than prospective, but you go backward. Prospective, how long you will follow patients can be a tricky thing, but while retrospective is not a big deal, and you go backward and عندي 10 years record, I can collect the data from. Prospective is precise, reliable, and really good for temporal association. Retrospective is good, but sometimes you have limited access to data. It can really affect your overall results. Prospective can really measure the confounders. Confounder اللي هو something can affect your outcome without really, without being direct cause, but it is association to it. While in retrospective you can have information or confounder, may not be a big deal. So again, case control is for prospective. If I to avoid selection bias because I include everyone at risk, I really follow up everyone and I don't really have my influence to follow people. بدل ما أقول له أنت smoke وخليه smoke, لا, it will not happen. بينما case control maybe I can influence them when I interview them, leading to information bias. Recall bias is not a concern for prospective لأنه I'm following them. But case control may be a recall bias. I'll just go quickly. We talked about this measure of association. اللي هو mainly I want you to be aware of odds ratio, relative risk. خليها. Then I just want to talk about the last quick. I still have few minutes and عارف 9:30 هنخلص. I have quick and then we take some break and we'll finish with the last part. So these are the measure of association. Now, a new medication, X medication, you want to test it to see if it will reduce the blood pressure. And it will be tested in patients who had hypertension but no other comorbidities. So now I'm really looking into a very specific group, only hypertensive without any other comorbidities. So my research question is, how will this medication affect the blood pressure in patients who had no medical comorbidities? Comorbidities, this is typo. So the population is patients with hypertension in the absence of other comorbidities. My intervention or exposure is this medication. My comparison is either placebo, giving nothing, or standard therapy or medication. And my outcome is change in the blood pressure, or to be specifically here, reduction in the blood pressure. So this is now a randomized study. So now I will have a sample with specific inclusion criteria. أبغى hypertensive, documented by blood pressure higher than 140/90, for example. And you see this is very specific. Who had no other comorbidities, ما حددت الage, ما حددت الsex, at least my inclusion criteria is very clear. And then I randomly, without my control, عشوائيا, randomly, I assign them to a group who will have the new medication and the other group who will have nothing, or they will have standard medication, different medications. And when I random them, when I give them medication, I check the blood pressure كلهم, the whole group. I check the blood pressure each time the same way, the same condition, عشان to minimize variation, to make sure the way I measure the blood pressure is reliable and valid. حتى different researcher, but at least it is reliable and valid. I don't know when I measure the blood pressure, did this subject receive the new medication or the old medication? So I'm blind. Sometimes even the patient is blind. He doesn't know, is this the new medication or I only give him like a fake tablet or sugar tablet. So there is blinding. I don't know. ليش blinding هذا? To avoid recall bias, to avoid information bias. أنا ما عارف. I just check his blood pressure. I go, did you take the medications? Did you take the tablet? And I don't know what tablet is. And make sure he's compliant. And then after the study, within 4 weeks, 6 weeks, I look at blood pressure. I will find people who had improved blood pressure in those who received the new medication versus never had an improvement in blood pressure. And the same for the placebo. مظبوط. So now this is randomized and this is blinded. I don't know. So this is a good example of randomized control trial. So this is an experimental trial. Now we are really going higher up in the hierarchy of evidence, and I follow them over time. So randomization again, يعني I assign them randomly عشوائيا. يعني يجي مريض أقول له مثلا it can be computerized يعني كمبيوتر يخش المريض أحط له subject ID في study and then the computer will generate and you will go to group 1, group 2, group 1, group 2. Maybe the principal investigator only will know ولا observer على plus the observer على الstudy بس إنه a patient never know which group he will be in. Those who assess the blood pressure never know where he will be, which group. Sometimes even those who, the person who will do the data analysis will never know. عنده two groups مو عارف is this the study group or this is the control group or the placebo. So this is the theme for the randomization. طيب. One quick word على الconfounding. Example is the randomized control trial will minimize bias لأنه I'm randomizing ما تقول أنا عملت selection bias أنا اخترت هنا وهنا طيب. I also minimize confounding. إيش confounding? For example, coffee probably will lead to pancreatic cancer. I know those who drink a lot of coffee, they also smoke a lot. So there are some association between coffee and smoking, but also smoking may lead to pancreatic cancer. If I only do the study without considering smoking, good coffee will lead to pancreatic cancer without considering smoking, I never looked at the confounding. So my randomization, with this way, you really estimate the effect of smoking because you go randomized. I just want to finish here. This is another example. I just want to go through this quick because of the time, sorry. Here, this is just the idea, and you really need to consider the confounding, something associated with the exposure that may lead to the outcome, but you have to consider it when you do the analysis. Again, why we randomize? We don't. It is not a matter of having equal group. It is a matter to really minimize the bias and to make sure we have. We start at a very comparable group more or less. And I think I am going to نتكلم عن type of blinding, single blind اللي هو only the subject never know what intervention he received, but those who check them they know, or double blind subject and examiner, or triple blind حتى the data analysis he never know. And I just go quickly. This is the scheme usually to the randomized control trial. You have eligible groups. You have to be very specific, exclude them, and then you randomize them to two groups. You observe the outcome, good outcome or poor outcome. This is the gold standard for therapy. This is very good for causality, of course. If I give you this medication, it leads to the reduction in blood pressure. So this medication causes the reduction in the blood pressure. Minimal bias and minimal confounding. This is the overall thinking of how would you think of your study, observational versus experimental. طبعا كل الستاديز اللي قلناها ما عدا randomized control trial are considered observational study. It has a good value. Experimental has a better value. Again, I just keep showing this because this is important. I think this is for now. And I will start some questions, and I like to really have this discussed if you want. بعدين آخر حاجة about the methodology. I think we're good in time. Zainab, you can drive.